This is a podcast for nursing 242 for fetal heart rate monitoring. This is part 1. Okay, so fetal heart rate monitoring, first off, who needs to have it done? There are some questions we should address. Should all women have continuous electronic fetal monitoring in labor, or should it be intermittent? So this is kind of a complex issue. It really depends on the patient, her health status, her pregnancy, her labor status. If a woman is healthy and is having a normal, healthy pregnancy and is low risk, there really isn't a good reason for her to have continuous electronic fetal monitoring. All women should have some fetal monitoring. Intermittent is actually quite sufficient for women who are of a low risk status. Unfortunately, that is not really what we're seeing in practice. So the next question is what has fetal monitoring done for us? Has it decreased neonatal mortality and morbidity? Is there benefit for women having continuous electronic fetal monitoring? And the answer is actually no. All continuous electronic fetal monitoring has done for us is increased our C-section rate. It has not done anything to decrease the rate of cerebral palsy. We do see that most of our patients, though, due to nursing constraints and things like that, are having continuous fetal monitoring in labor. It's much easier as a nurse to monitor 2 and 3 patients in labor if they're on continuous monitoring and we're watching their fetal heart rate tracing at the nurse's station versus having to actually go into the room and put our hands on the patient and do intermittent fetal monitoring. So that's why sometimes you see that even though it's not good evidence-based practice. So this is an example of electronic fetal monitoring. This isn't the greatest picture because typically what you're going to see is there's going to be 2 belts on the patient's belly and 2 transducers. One which is going to be for contractions, which is usually placed like it is in this picture. You can see it right here at the top of the uterus, what we call the top of the fundus. And then the ultrasound transducer will be placed on to hear the fetal heart rate. And where it's placed on this picture is not good placement. And actually the best place to hear the fetal heart rate would be in between the shoulder blades on the baby's back. Some places now have telemetry monitors, so it's just like our patients who are on cardiac units. Instead of the monitors being attached, or excuse me, the belts being attached to the big monitor where the patient can't really move about, there is a smaller box that we can attach it to so the patient can be upright and moving about. Some of the drawbacks to this, the external fetal monitors, so the one for contractions, or what we call the TOCO, doesn't really tell us how strong contractions are. All it's going to tell us is how often contractions are coming and how long they last. It does not tell us anything about strength. The downside to the external monitor for fetal heart rate is that it doesn't always give us a consistent reading of the fetal heart rate. If mom moves or the baby moves, we may have to adjust the monitor, so the tracing can kind of come in and out depending on movement of both mom and fetus. So this is what we're going to see on the actual monitor display and what's going to print out on the paper. So you'll see there's 2 parts to this. The top part is where the fetal heart rate is, and then the bottom part is where the contractions are going to print out. So here's another example. On the fetal monitoring paper, typically you're going to see dark red lines like these, and then in between you're going to see smaller blocks of time. From dark line to dark line is going to be 1 minute, and then the smaller blocks here are 10-second increments. Okay, so fetal heart rate tracing is going to be in the upper portion. Bottom portion are going to be uterine contractions, or what we call uterine activity. Some of our terminology is now starting to change. There's several handouts I've put in your packet that talk about how to describe fetal heart rates and how to describe uterine contractions. Sometimes you'll see contractions explained, oh, they're coming every 2 to 3 minutes, or they're coming every 5 minutes. Sometimes what you'll see, and what most of us are now following, is a new way to describe them and document them, which would be how many uterine contractions we see or palpate in a 10-minute time frame. So you might say the patients, like in this tracing here, patients having 3 contractions in 10 minutes. Both of those are perfectly acceptable. The way we time contractions, so the way we know, are they coming every 2 minutes, every 3 minutes, 5 minutes, how often are they coming? You time a contraction from the beginning of one to the beginning of the next one. So for instance, if you look at these here, this is where this contraction starts. So you have 1 minute, 2 minutes, not quite 3 minutes. So these contractions from here to here are about 2.5 minutes apart. So then you have another minute, 2 minutes. These two from this one to this one are about 3 minutes apart. So by looking at this tracing, you could say the contractions are, about 2.5 to 3 minutes apart. So, as I said, the contraction monitor, or the TOCO, is placed on the uterus to assess the frequency and duration of the contractions. We have to actually put our hands on the patient and palpate her abdomen to see how strong they are, or we could ask the patient to rate the pain, or just our overall observation of how she's coping with her contractions can be helpful. What we don't want to see, especially with the number of inductions we're doing, is something called uterine hyperstimulation. So that's when we're having more than 5 contractions in a 10-minute time frame, or if we're having essentially contractions that are coming about every 2 minutes. That's too frequent. What you can see, what happens here is you're having a contraction, the uterus barely gets to relax. We're having another contraction, the uterus barely relax. So we're just cranking contractions out one after another after another. In this tracing, the baby looks like it's tolerating it okay, but after a period of time, the fetus usually isn't going to be able to handle that, and will start to show some periodic changes in the heart rate, which we're going to get to in a few more slides. Okay, so assessment of fetal heart rate. What do we do? How often do we assess? So we have the American College of Obstetrics and Gynecologists, or what we call ACOG, and they're who set most of the guidelines. So they state that intermittent auscultation of the fetal heart rate is equivalent to continuous electronic fetal monitoring in detecting any problems with the fetus. The recommendation, though, is if we're doing intermittent monitoring, that we have a 1-to-1 ratio, so 1 nurse to 1 patient. So the recommended intervals, if we're doing intermittent monitoring, for the low-risk patient, we should be listening about every 30 minutes in the active stage of labor and every 15 minutes in the second stage of labor. For the high-risk patient, we should be listening every 15 minutes during active labor and every 5 minutes in second stage. What you're going to find in practice, though, is that high-risk patients are typically almost always going to be on continuous electronic fetal monitoring. So terminology that most of us are using now, it's called NICHD terminology, and you guys have an article in your packet that goes over this in more detail and gives you lots of examples of fetal heart rate tracings. And this is kind of a standard criteria that we're all using to document. So when we're looking at the baseline rate, so what is the fetal heart rate baseline? They have a baseline heart rate just like we have a baseline heart rate. Our heart rate might go up if we're exercising, if we're sleeping or resting, it might go down a little bit. So what we're looking for is the fetal heart rate during a 10-minute segment of time, and we're excluding any what we call periodic or episodic changes, and we're going to go over those in a few more slides. When we're looking, we want to find a portion of the tracing where the patient is not having a contraction to see what the baseline heart rate is. So kind of our cutoffs are our parameters. Normal fetal heart rate is anything typically between 110 beats per minute up to 160 beats per minute. So definition of bradycardia would be if that baseline fetal heart rate is less than 110 beats for at least a 10-minute time frame. If it's less than 10 minutes, it may be a fetal heart rate deceleration or something else that's going on. Tachycardia would be where you have a baseline heart rate that's greater than 160 for 10 minutes or longer. So let me show you some examples. So this is an example of fetal heart rate bradycardia. So you can see all paper is usually pretty standard. So right here is 60, so you've got like 70, 80, and here's 90. So this fetal heart rate baseline is about 80 beats per minute, which is entirely too low. There can be lots of causes of bradycardia. It could be things like maternal drug use or abuse, placental abruption, congenital heart defects in the fetus. Okay. Then we have tachycardia. So once again, that's where the baseline fetal heart rate is going to be greater than 160 for at least 10 minutes. So you can see right up here is 160. So this is 170, and then 180 is up here. So this baby is about at 175. Lots of different causes for fetal tachycardia. Could be things, anything that can increase mom's heart rate can increase baby's heart rate. So maternal fever, certain medications, drug use, any type of infection in mom or baby can cause fetal tachycardia. Anemia and hypoxia can also cause tachycardia. So here's an example of another tracing where there's tachycardia. Let me go back one more time. You see in this one we have tachycardia, and the tracing is really, really flat as well. There's not a lot of what we call variability, which we're going to get to in a slide in just a minute. So this is a little more worrisome than this tracing. In this tracing, yes, we have tachycardia, but we also are having what we call accelerations, where the fetal heart rate is speeding up, and we have really good what we call variability, so this variation in the baseline of the baby's heart rate. So we're going to talk about variability in a minute. So this tracing, while the tachycardia, we need to figure out the cause of it and hopefully resolve that cause. This tracing is not quite as worrisome as the one where we saw before, where the heart rate was really flat and kind of consistent without that variability. So what is variability? Variability is the fluctuations in the baseline fetal heart rate. So we have 4 different criteria that we use when we're describing fetal heart rate variability. Okay, so the first one is absent variability. So I'm going to go through and show this to you in the slides. So in absent variability, basically the variation of the heart rate is what we call undetectable. So in this tracing, the baseline fetal heart rate would be 148. And you can see there's basically no shift from that. There's very, very little movement in the fetal heart rate. You can almost draw a straight line with how it looks. Then we have minimal variability. So in minimal variability, we have basically a variation of less than 5 beats per minute. So in this tracing, our baseline is about 138, and you can see we have a few little periods where it goes up just a tiny bit and down just a little bit, but really within kind of that 5 beat range. So when we're seeing absent and minimal variability, like these first 2 tracings here, can be some causes for that. One of them could be as simple as what we call a sleep cycle. Babies do have sleep cycles in utero. During their sleep cycles, they're not moving a whole lot. We're not seeing a whole lot of variation in their heart rates. So if we're seeing this and it lasts for a short period of time, it's not necessarily always terribly worrisome. Also, if mom has just received sedation, so if we've just given her some narcotics for pain control, we can also see absent or minimal variability. Sleep cycles don't last typically more than about 30 minutes. If mom has received a narcotic, we expect, depending on the med and the dose, that narcotic to start wearing off within 30 or 60 minutes in terms of the effect on the fetus. So this is a pattern that we shouldn't see for very long if it is present, and it's present because of something benign like a sleep cycle or because of a medication. What we want to see is what we call moderate, or sometimes you'll also see it called average long-term variability. So this is where the variation is going to be between 6 and 25 beats per minute. When we see this, this tells us that we have a very well oxygenated fetus. So for an example, in this tracing here, I would say the baseline fetal heart rate is about 130. So it's right in here in the middle. Then we have what we call marked variability. So marked variability is kind of the extreme on the other end. That's where the amplitude or the variation is greater than 25 beats per minute. And there can be many different causes for this as well. Sometimes it can just be because the baby's really moving a lot, and maybe we're picking up on a baseline with lots of accelerations or just changes because of all the movement. But marked variability is not something that you want to see for a long period of time, just like you don't want to see minimal or absent variability for very long either. Then we have a pattern that's called sinusoidal. So it looks like little waveforms, basically. When we see a sinusoidal pattern, it's usually because of maternal drug use or severe fetal anemia. So this is not a pattern you're typically going to see, and if we see it, it's usually something that we have to intervene on pretty quickly, because this is a fetus that could potentially be pretty compromised. So here, this is just another example of the 4 different types of variability that we just talked about. Absent variability, minimal, moderate or average, and then marked variability. So let's talk about accelerations. Accelerations are what we call an increase of the fetal heart rate above the baseline. Okay. Typically, they're going to be at least 15 beats above a fetal heart rate baseline. Okay. In babies that are less than 32 weeks, usually accelerations will be a little bit smaller because their central nervous system is not as well developed as it is in a more term or closer to term fetus. So you may see smaller accelerations. 10 beat per minute acceleration, that is up there for about 10 seconds, is a little bit more of what we expect for a baby that's less than 32 weeks. Accelerations are a really good sign. Accelerations tell us the baby is well oxygenated, and typically they are going to coincide with fetal movement. So it's just like if you were to get up and run around the room a little bit, your heart rate should increase with that activity. It's the same thing with the fetus in utero. We have something called prolonged accelerations. That's where the acceleration lasts for longer than 2 minutes, but less than 10 minutes, because if it lasted for more than 10 minutes, it would probably put us into the category of tachycardia. So sometimes we have to do a test called a non-stress test. So a non-stress test is when we're going to put a patient on the fetal monitor. Let me go forward 2 slides to show you guys. We put the patient on the fetal monitor. It's called a non-stress test because we're not stressing the fetus in any way. We're only challenging, or excuse me, we're not challenging the fetus. We're only monitoring the fetus. Okay. So let's go back 2 slides and talk about what are some of the reasons we would do a non-stress test on a patient. Sometimes we do them when they're in labor. A lot of times we do them, though, prior to the onset of labor for different conditions or issues. Non-stress test is going to let us know, is this baby well oxygenated? Is the baby seeming to be under any distress or stress? How are things looking? So reasons we might do one: if we know the patient is overdue, or we suspect maybe they are. Sometimes women present very late for prenatal care. We might not know how far along they are. If there's maternal diabetes, maternal hypertension. So this could be if she has chronic hypertension, pregnancy-induced hypertension, preeclampsia, if she has a history of a previous stillborn, especially if it was for an unexplained reason, if she has polyhydramnios or oligohydramnios. So those are, polyhydramnios is an excessive amount of amniotic fluid, oligohydramnios is a less than normal amount of amniotic fluid. IUGR is intrauterine growth restriction. If there are any known fetal anomalies. Other reasons could potentially be an older gravitas, so an older mom. That doesn't necessarily mean, women who are 35 or older. A lot of times it's more the ladies who are going to be 40 or over at the time of delivery that we're a little more concerned. They have a higher risk of mortality and morbidity, so we tend to do more monitoring on them. If a patient complains of decreased fetal movement, we might do a non-stress test. If we know that there's severe maternal anemia, so not just iron deficiency anemia, but if it's very severe. Multiple gestations, so twins, triplets, and so on. If mom has any high-risk antepartum conditions, so premature rupture of membranes, which is what PROM stands for, if she's having bleeding or preterm labor. And then if she has any chronic renal diseases might be another reason. And there's certainly other reasons and conditions, and these aren't all inclusive. Some people have some of these conditions, but we're not doing non-stress tests. Some people don't, and we're doing them, so you'll see some variation in this practice. Okay, so what we're looking for with the non-stress test, we're looking for something that is what we call the 15 by 15 rule. So what that means is those accelerations, or those times when the heart rate speeds up, which we just talked about a couple of slides ago, that acceleration should be at least 15 beats above the fetal heart rate baseline, and it should remain up for at least 15 seconds. Now, if the patient is less than 32 weeks, typically we're going to be looking for a 10 by 10 rule. So the fetal heart rate should go 10 beats above the baseline and stay up for 10 seconds. We don't routinely do non-stress tests, though, on patients who are less than 32 weeks. Usually 32 weeks is when we start doing them if they've got a condition or something we want to monitor them for. Okay, so here's an example of what we call a reactive non-stress test. So this is what we want to see. So non-stress tests can happen with or without contractions. Contractions really don't have anything to do with it. They can be present, they can be absent. It doesn't matter. What we're concerned about is the fetal heart rate. So what you have to do first is determine what is the fetal heart rate baseline, because that's how you're going to be able to follow your 15 by 15 rule. So in this tracing, we would say the fetal heart rate baseline, so here's 120, it's 130. You guys can see here how the baseline is typically, for the most part, right on 130. So we know our baseline is 130. So our accelerations need to go up at the bare minimum, at least up to 145. So let's look at these accelerations, these times when the fetal heart rate speeds up. So here on this one, we're up to about 150. This one's a little bit below. This one's up to 160. This one's up to 160, 160. This one goes up to 170. So we know we have at least two. We have 1, 2, 3, 4, 5, 6 that meet that criteria of going up at least 15 beats above the baseline. And then we need to make sure that they're lasting at least 15 seconds. Well, remember, each of these small blocks from light line to light line are 10 seconds. So this one is 10, 20 seconds, 10, 20 seconds. So right there we know we've met criteria. This one is 10, 20, 30 seconds, and so on. You can count through the others. So this is what we call a reactive non-stress test. We are meeting that 15 by 15 rule. We've got a baseline of 130. We're having accelerations, most of them are up to 160, and most of them are lasting 20, 30 seconds. So what this is telling us is that this fetus is moving well and it's well oxygenated. Okay? So then we have an example here of what we call a non-reactive non-stress test. So in this one, once again, our baseline is 130, just like in the previous tracing. We're not seeing any accelerations, we're not seeing any decelerations, which we'll get to decelerations in part 2 of this podcast. I'm also not seeing any contractions here. So reasons we can see a non-reactive non-stress test. One can be a sleep cycle, like we just talked about just a little bit ago. Maybe, the fetus is in a sleep cycle. Other reasons could be things like if mom has had sedation. So if she's received any type of narcotic, whether she's taking it off on the street or we've given it to her for some reason. If she's a smoker, women who smoke cigarettes, if they smoke prior to a non-stress test, it usually takes anywhere from an hour or longer for this pattern to go away and for the fetus to actually wake back up and for the effects of the nicotine to clear the fetus's system. Other reasons could be low blood sugar, if mom's diabetic, or even if she hasn't recently had a meal, if she's not well hydrated. So there are lots of different reasons we can see a non-reactive non-stress test. Usually we give the patient about 30 minutes, and if we don't start to see some signs of a reactive non-stress test, then we may start to do other testing or check other things out. But remember, we talked about a sleep cycle can last about 30 minutes. So there are some things we can do if we see a non-reactive, non-stress test. We don't typically just sit there and watch it for a half an hour and do nothing. First off, you want to do a thorough assessment and ask the patient those questions. Are you a smoker? When did you last have a cigarette? When did you last feel your baby move? Has the baby moved recently? When did you last eat or drink anything? If she's a diabetic, I want to check her blood sugar. I want to know what her blood pressure is. If she has high blood pressure or low blood pressure, that could be a reason for this. You want to make sure if you're doing the non-stress test, the patient isn't laying flat on her back. If you remember back to the changes in pregnancy, women don't perfuse well in pregnancy if they're laying flat on their back, and that gravid uterus is pushing down on her aorta and her vena cava. It's going to decrease the perfusion to the placenta. It's going to decrease the perfusion to the baby. So I want to make sure that she's over on her side. If she doesn't have any risk factors or reasons we wouldn't want to hydrate her or give her something, you can give her a drink, give her a snack to see if that can help wake the baby up and get the baby moving. Okay, so we just talked about what are some of the potential causes. So things like drug use, tobacco, low blood sugar, not eating or drinking recently, appropriate nursing management of this non-reactive, non-stress test. We're going to change her position. We're going to do good assessment. We might PO hydrate her or give her a snack. Another thing we can do is something called a VAS, which is basically a vibration acoustic tool that we use, and it basically, you put it over the mom's abdomen, it buzzes a little bit, and essentially can wake the fetus up in utero. So some places use those. If we've done a thorough assessment and we've done all these things, and it's been 30 minutes and we're still not getting reactive non-stress tests, we want to notify the healthcare provider and probably anticipate an ultrasound and potentially a test that we call a biophysical profile may need to be done. And this is where we're going to stop for part 1 of the podcast. There will be a part 2 as well.